Hello and welcome. I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have a distinguished panel joining us to discuss the current data about boosters for COVID-19. Dr. Paul Offit is Director of the Vaccine Education Center and Professor of Pediatrics in the Division of Infectious Disease at Children's Hospital of Philadelphia. Also joining us is Dr. Paul Sachs, Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Welcome, gentlemen. Current data indicates that about 66% of the US population is now fully vaccinated or up to date, according to the new CDC terminology, with about 40% of this group having received a booster or third shot, how you want to refer to this. And we do have 3 recent studies from the CDC that indicate the importance of the booster or third shot to protect against the Omicron variant. So let's talk about recent studies from the US and overseas that indicate this ability of boosters in preventing infection, hospitalizations, and deaths. And we'll start with Dr. Offit.
Sure. So we have to ask ourselves the question, what's the goal of this vaccine? I think the goal of this vaccine was what the goal should be for every vaccine, is protect against serious illness, meaning the kind of illness that causes you to go to the doctor's office or the hospital or the ICU or the morgue. You could argue that 2 doses of mRNA-containing vaccine have done that for the most part, and I'll get to the specific groups where that hasn't been true. But I think if you look, for example, at young healthy people, protection against moderate to severe disease is mediated by immunological memory cells, like memory B cells, memory T helper cells, memory cytotoxic T cells. The immunological component, i.e. epitope, that's recognized by those cells is generally conserved. So even though the vaccine was made against the original strain, the so-called Wuhan 2020 strain, the ancestral strain, and we've had 4 different variants that have come into this country, D614G, then Alpha, then Delta, then Omicron, protection against serious illness has held up. Now you can argue that a third dose, this is a 3-dose vaccine for certain groups. I think for people over 65, for people who live in long-term care facilities, the data are clear. I think the data are also pretty good for people who have comorbidities that are over 50. Where I think it's less clear is how a booster dose in an otherwise healthy young person increases protection against moderate to severe disease. I don't think those data, frankly, exist. So I think while it's a good idea to say have a permissive recommendation for people over 12 to arguably get a third dose, I think making that a formal recommendation, which is meant for a lot of mandates to get third doses on people who probably aren't going to benefit from it in terms of protection against serious illness. Now, on the other hand, if your goal is to try and prevent against all symptomatic disease, mild disease, that's mediated by neutralizing antibodies, which fade. And I think the seduction that we had back in December when our committee, the FDA Vaccine Advisory Committee, considered sort of the Pfizer Moderna vaccine, protection against mild disease was 95% for those 2 vaccines. But that's because those were 3-month trials. So people had just gotten a second dose. The neutralizing antibodies had to fade and did. And then I think the communications error that we made was ever calling a mild illness a breakthrough infection. That's not a breakthrough. A breakthrough is when you're hospitalized despite being vaccinated. It's to expect that these kind of vaccines, mucosal vaccines, are going to protect you against mild disease is a lot to ask. And I think it's an unrealistic bar.
Absolutely. And Dr. Sachs, how would you respond to Dr. Offit's comment?
There is a cost to breakthrough cases, no matter how mild they are in the current pandemic, which is that they're tremendously destabilizing for workers, for families, for kids in school. So if there is a potential benefit of reducing the risk of infection, symptomatic infection, even mild, then that would be a worthwhile goal, especially if it does translate into reduction in risk of transmission. Now, I'm not saying that people who break through are less likely to transmit than people who don't who are unvaccinated, but that might be the case. But if you can reduce the risk of transmission, and there's some evidence that within vaccinated households, transmission risk is lower.
And I think we should talk about children. Certainly the age group, 5 to 11 is a concern, and 12 to 19 or 12 to 18. These are important populations that are well under vaccinated. And certainly, Dr. Offit, you can understand this as a pediatrician. And we need to reach these groups. So how can we do that better? What are we not doing right now?
Right. I mean, the largest group of people who are unvaccinated in this country are people under 30. So, I hear certainly from parents, when are we going to have a vaccine for the 12 to 15-year-old? When are we going to have a vaccine for the 5 to 11-year-old? So we had a vaccine for the 12 to 15-year-old in May, and about 55% of people in that age group are vaccinated. We had a vaccine for the 5 to 11-year-old by the beginning of November, 3 months ago. About 20% of that group is vaccinated. Presumably, we may have a vaccine for the less than 5-year-old soon, but I suspect that the immunization rate will be even lower in that group than in the 5 to 11-year-old. So we talk about wanting a vaccine, but then when we have them, we don't use them. How do we get people less than 30 to get vaccinated? Because they are the largest group that's unvaccinated. I think that it really comes with the pediatrician. I think generally people trust their pediatricians, and I think we maybe need to be a little more proactive about this.
Right. And Dr. Sachs, how would you follow that up?
Well, I mean, I'm married to a pediatrician, so I have some credentials here. I was going to say that immunization is sort of front and center of the preventive health that they do. One of the, I think, crowning glories of the American public health system has been actually school mandates for vaccinations, and it's one of the reasons why we have smaller, less frequent outbreaks of things like measles in the United States than they do, for example, in Western Europe. So I think at some point, if the decision is made that the benefit of vaccinating children outweighs the risk and it's better for society as a whole, then I think we'll move in that direction. And I'm hopeful we will, just because I do think it will stabilize things. This last Omicron wave, wow, the number of pediatric cases was just astronomical, way higher than any of the previous waves, and that's partially because schools were open. What do you expect? Kids transmit the viruses. Fortunately, most of the time they were very, very mild illnesses.
Did you see an increased incidence of MIS-C in this cohort? When you're saying pediatrics in general with this greater exposure and more infections?
It seemed to me that when months ago, when we were seeing children come in with COVID, we saw a lot of MIS-C. It was one of the most common diseases to come into the hospital. It's primarily a disease of the 5 to 13 year age. It sort of peaks at about 9 years of age. With the Omicron wave, I haven't seen as much MIS-C. I'm sure there are data published on this, but we haven't seen as much MIS-C. Omicron is different, I think, in two ways. I think it is less virulent. I mean, there's two studies. One came out of California, another out of Cleveland, that you are more likely to be admitted to the hospital or the intensive care unit or be mechanically ventilated if you're infected with Omicron as compared to Delta. And it's always hard to sort of separate out population immunity, which has obviously increased over time. So I think it is somewhat less virulent. It's also immune evasive. That's the problem. I mean, even not contagious as much as immune evasiveness. I mean, even if you've been vaccinated and arguably even to some extent boosted, you're off target for protection against mild disease because this virus is different. I mean, Delta had a certain number of mutations in the receptor binding domain and the N-terminal domain. This virus has more than 30. I mean, it was like a leap upwards. And although people talk, virologists, talk about how coronaviruses aren't flu viruses. I mean, they don't drift. This is a drifted virus. This virus acts like flu, so it makes it a little scary.
One thing I think is interesting about Omicron also is that the place where it preferentially seems to infect and replicate is in the bronchus, in the upper airways, not in the lungs. And again, I've heard anecdotally that children are more likely to have croup-like illness from Omicron than with previous variants. I will say that for adults at least, the fact that it may not replicate as well in the lungs would be very much welcome because obviously the cause of lethal COVID-19 almost always is a pulmonary disease.
Right, and so that brings up a key question of mucosal immunity in terms of vaccine development. And maybe both of you could weigh in where we are in terms of vaccines that are looking at mucosal immunity or the target mucosal immunity.
Right. Well, I mean, so I was fortunate enough to be part of a team at Children's Hospital of Philadelphia that developed the strains that became the bovine human reassortant vaccine Rotatek. So have a fair amount of experience with mucosal immunity. I mean, the rotavirus vaccine is given by mouth because it then can stimulate immunity at the intestinal mucosal surface for a virus that really replicates almost solely at the intestinal mucosal surface. Viremia is not an important part of pathogenesis. You can make the same case for this virus too. This virus really doesn't have viremia, meaning virus in the bloodstream, and is an important part of pathogenesis. So you need good mucosal immunity, but It's not as easy to generate for the respiratory viruses as people think. I mean, so for example, flu mist is a nasal spray live attenuated vaccine, which people assume would be dramatically better in terms of inducing that response than was the inactivated vaccine or the purified protein vaccine that's given parentally, but it wasn't so dramatically better. It's not so easy to make these things. I know Dr. Fauci's recently talked about a pan coronavirus vaccine, a sarbecovirus vaccine, where you can sort of target all coronaviruses. Now the SARS-CoV-2 is really the seventh pathogenic coronavirus that's entered the human population. Not easy to do.
But a 60 Minutes broadcast about a few months ago said the US Army is close to having this pan coronavirus vaccine, which interestingly, I'm not sure who they're collaborating with, but it seems like, from what they're describing, they're close.
Well, I'm not sure that I would call that. So what the way they work, they have ferret in which they're able to sort of create in a structure that looks like a small soccer ball, onto which they can then put all these different SARS-CoV-2 spike proteins. I think when people think about pan coronavirus vaccine, what they're really thinking about is trying to figure out a way to develop an immune response against conserved parts of this virus that then will protect you against all, say, 7 coronaviruses that have those conserved regions. That's not easy to do because the natural infection doesn't do it that well.
So is that part of a mosaic approach essentially that you're describing, or is it when you say that conserved, or is it?
Yeah, so the conserved regions, so there are conserved regions that are recognized by T helper cells and CTLs and B cells on the SARS-CoV-2 spike protein. And for the most part, they've remained conserved. So that's even for Omicron. So that's good. Right. But what you worry about is that you really would need a variant specific vaccine, because I'll take a step back. When there was an outbreak of in Provincetown, Massachusetts, with thousands of men get together, celebrate July 4th, 79% are vaccinated, but nonetheless, 346 get COVID. Of those 346, 4 were hospitalized for a hospitalization rate of 1.2%. Those, by the way, were breakthrough illnesses. Unfortunately, the CDC called all those mild infections breakthrough illnesses. And if that 1.2% becomes 10% or 20% or 30%, then you have a failed vaccine. And now you're talking about a new vaccine, a variant-specific vaccine, if that happens.
I wanted to just switch gears and talk about the ideal time to get vaccinated if you're immunocompetent and if you're immunosuppressed. Because there was a Wall Street Journal article recently that kind of looked at this and really drew attention to the fact that people are confused. Like, do they get their booster or third shot right after they get better, after they're convalescent? Do they wait 2 months, 3 months, 4 months? I want both of you to weigh in on this because maybe you can help settle the confusion to some degree.
I think one of the most confusing aspects of COVID for our patients and actually for doctors too is how durable protection is after natural infection. And part of the reason it's so confusing is because it varies from person to person. It varies depending on the severity of the illness. It probably varies based on when you had it. So the durability and the protection are all over the map. And there are plenty of people who get reinfection. And sometimes the reinfection is more severe than the first infection. So I wish that I could say that infection protects you. You'll never get severe disease again, but that's clearly not the case. So there are immunologists who feel like, yes, once you get infected, you can wait. You have 3 months at least, and you're not going to get reinfected. And there are other immunologists who feel like the infection actually harms some of the immune responses, and you should probably get vaccinated as soon as you can. So I don't think we have enough data to say what the optimal time to wait is.
Dr. Offit, any thoughts on that?
Yeah, I think, when this vaccine launched, back in December, the Pfizer Moderna vaccines, you had 3 or 4 week intervals between doses. And the thinking at the time was that had this not been a pandemic, this would have been a 3-dose vaccine because you would have wanted to have, let's say, a 4 to 6 month interval between doses, whether it was the first and second or second and third, sort of based on, what we had learned about purified protein vaccines, or what we learned about inactivated viral vaccines, where in order to get really high frequencies of memory B and T cells, you needed that interval. I'm not sure how this is going to play out because it's at least when you look at studies by John Weary or Shane Crotty at La Jolla, at least when they look at frequencies of memory T helper cells or memory cytotoxic T cells, they have for the most part held up. And maybe that's because this is more like a live attenuated viral vaccine in that you're making the viral proteins in your own cell. You're not being given passively those proteins. I don't know. I mean, I think we're going to learn over time. It does look like the so-called hybrid immunity, which is induced by sort of a combination of natural infection and immunization, provides, sort of maybe certainly broader protection, possibly longer lasting protection. We'll see. But it is confusing. When the virus first came into this country, I mean, back in, January of 2020, what people were looking at was, did natural infection protect against at least moderate to severe disease associated with reinfection? The answer was, for the most part, yes. I mean, there certainly were people who could get seriously ill twice, but this wasn't like a pathogen like strep. You can get strep throat again and again, or gonorrhea you can get again and again, and natural infection doesn't protect you. That wasn't true here. I mean, natural infection does to some extent protect, but as Dr. Sachs said absolutely accurately, is the dose is variable. When you get a vaccine, you're getting a defined dose. When you're getting naturally infected, it's an undefined dose. So therefore, there's variability in protection. But I think that the combination of natural infection and vaccination is probably your best bet in terms of broad immunity.
Yeah, I mean, there's already data that, these mild Omicron cases may not actually induce as much protective immunity as other infections. And that's a sad thing. I mean, you'd like for a mild case to be very protective, but it seems to be very much like the Goldilocks phenomenon. Like, you don't want to get severe disease because that's life-threatening. You don't want to get mild disease because it's not very protective. You want something that's sort of just right, but it's you can't titrate that. And that's why I think that the fans of natural infection as a strategy for protection, it really doesn't make a whole lot of medical sense as a strategy. And I would actually just say that for people, for at least the advice I give people, once they've recovered from COVID, they're fully recovered, then they should go ahead and get their booster when they're ready. And it doesn't have to be, it's not urgent, but they also don't have to wait 3 months.
Right. But I thought there's some data showing that waiting, is better in the sense of having a more robust effect. I guess we don't have the data. Is that what you're trying to say? I mean, there's conflicting. Yeah.
I don't think we have the data looking at waiting strategies after infection to see which vaccine strategy is most effective. I'd be very surprised if those data exist, but maybe Dr. Offit knows.
No,
Okay.
I mean, I think that there's probably 5 papers now showing that if you've been naturally infected and you get, say, a dose of an mRNA vaccine, it does act as if it's your second dose. I think when you have people who are naturally infected, they've gotten like 2 doses and now they're being asked to get a 3rd dose because they haven't been boosted. I think that's a little silly. And I think by making that a mandate, for example, to get onto university campuses, we've created a fair amount of angst there.
Right. The CDC steps out of it and says really that you can get it at any time, essentially. They're saying once you're recovered, so they kind of step out of the ring.
Yeah, I mean, people look for specific guidance, and in this very fast-moving area, there's a lot of things change very quickly. I mean, one of the things that's so challenging about COVID, as you know, is that the data are coming at us very, very fast, and we have to keep revising what we are recommending. And we're not revising it because we're being capricious. We're revising because there's new information. I mean, nobody expected a virus as diverse as this when it appeared in Thanksgiving Day 2021.
Got it. And now we have the stealth variant. So I think maybe we can just dive into this superficially at this point in terms of where do we go from here? Are we looking at a more transmissible variant than the original Omicron? Dr. Offit.
Well, yeah, it looks to be somewhat more transmissible. Yes. The good news is it still retains those epitopes that are recognized by memory cells. So it looks like you still are going to be protected against serious disease if you've been vaccinated.
Okay.
And it doesn't appear to be more virulent. But it does appear to be somewhat more contagious. At least those are the data from Denmark.
Yeah, there's a very interesting study from Denmark, and I feel like I always should cite the specific numbers because their household transmission for this B2 variant of Omicron, more transmissible, was up at around 40%. And people think household transmission is virtually guaranteed with these more transmissible viruses, but they really aren't. And anyone who's in clinical practice knows that there are households where, for whatever reason, one person gets infected and the other 4 living there, even in close settings, don't get it. And other households where everyone gets it, it almost certainly has to do with the amount of virus in the source patient.
Right. How about like a few key takeaways from both of you? Dr. Offit, I'll start with you.
I think that we're getting there. I do. I mean, if you look at population immunity defined as being naturally infected or vaccinated or both, you're probably about 90% of people who are, for the most part, protected against moderate to severe disease. That's good. I do think that there is a seasonal component to this. I mean, if you look at last year when we had a very small percentage of the population that was vaccinated or naturally infected, when you hit mid-February and then late February, you clearly saw a decline in hospitalizations and deaths. So I imagine as we move into spring that you would see that now also. Even when you look at last summer, we were way down in hospitalizations and deaths, and I think that should be the focus. I really don't think cases should be the focus because, especially with Omicron, I mean, there's just gonna be a lot of cases, and I think we're driving ourselves crazy a little bit. I would say this, though. I think in the end, we're not gonna boost our way out of this pandemic. I don't think we're gonna mask our way out of this pandemic, and I don't think we're gonna test our way out of this pandemic. I think we're gonna have to vaccinate our way out of this pandemic. And over the next couple of years, I think you're gonna have two choices, which is to be vaccinated or be naturally infected, and vaccination is always the better choice.
Yeah, I think on a very practical level, if you're a doctor or a nurse or a PA caring for someone who's over the age of 50, especially if they have medical comorbidities, and they haven't received their third dose, I would strongly recommend that they do so, because in our hospitals still, that's the population of the vaccinated people who are sick enough to be hospitalized. It's predominantly people with medical comorbidities or who are older. And so protect them, really focus on that group and tell them it's a 3-dose vaccine. I mean, it may require an annual or some frequent top up, or maybe require modification, but for now it's a 3-dose vaccine.
Okay.
I completely agree with that, by the way. I do. I think that's in the adult hospital hub, next door to the Children's Hospital of Philadelphia. When they see adults that are there who would have benefited from a booster, it's because they have usually more than one comorbidity, or they're older, or they have more than one comorbidity. I think that it's a 3-dose vaccine for that group. I think the thing that just upset me a little bit was when we sort of had a universal recommendation for healthy young people for a 3rd dose, because I just didn't think the data were as strong for that. But I seem to be an outlier there.
Well, thank you again. I really appreciate you both taking the time. It was a great discussion.
Thanks a lot.
Thank you.